I'm going to introduce, and now I'm going to introduce Angel for his November 2022 in service on pain treatments. So Angel, it is all you. If you are ready, it's all you.
I'm having a little bit of trouble. Let's see. How can
That's
I
okay.
access my, okay, this should be. You guys can see my screen, right?
Yes, we can. And now we're at the very front page.
Perfect. All right, let me move this. Awesome. So, like Dr. Baldwin said, my name is Angel Aviles Ortiz. I'm a 2023 PharmD candidate, and I will be talking today about pain treatment. Our objectives for today include to define the pathophysiology of pain, summarize different types of pain and goals of care, and also to describe the different treatment alternatives that we have available for pain. I want to start this presentation by actually describing what is physical pain. Physical pain is considered to be an unpleasant sensation and emotional experience that usually is caused by some type of damage to the body. It also represents the body's natural response to prevent further tissue damage. It is subjective, which means that each patient gets to experience pain at a very different way, which oftentimes makes it difficult to diagnose and treat because of how personal it is to each individual. So how do we feel pain? We have different signals that will travel through our nerve fibers to the brain for our brain to interpret these signals. And this could happen after a certain trauma, whenever there's tissue damage, whenever we suffer from an injury, and many other causes or issues can cause pain. We have our nociceptors, which are receptors that are in charge of detecting whenever we suffer from tissue damage. And these will transmit that information along the spinal cord to the brain, and the brain will pretty much interpret these signals and cause the pain. The common example of this is whenever we touch a hot surface, this will send an immediate message into the spinal cord, causing an immediate muscle contraction reaction. And the reaction will ultimately cause us to remove our hand from the hot surface. So what are the common causes of pain? We have many illnesses or disorders like the flu, arthritis, endometriosis, fibromyalgia, and many other illnesses that can further contribute to us experiencing either acute or chronic pain. Other common causes can be something as simple as a headache, toothache, a sore throat, stomach cramps, muscle cramps, burns, cuts, bruises, bone fractures, and many other causes. So super important to differentiate between acute versus chronic pain. Acute pain has a definitive starting point, and when we compare it to chronic, whenever that chronic pain began to happen, it is unclear. Now, acute pain has a protective response, which could be a physiologic benefit. Now, when we compare it to chronic, we pretty much don't have that physiologic benefit. Acute pain will improve once our body starts to heal or starts to attack that cause of the pain. However, when our patients experience chronic pain, there is no acute injury to heal. Acute pain responds pretty much to either non-opioid and opioid analgesics, but when it comes to chronic pain, that response can be moderate, or sometimes there is no response at all. Super important to know the time. When we talk about acute pain, the time can be a few weeks or months, but when it comes to chronic pain, it can be greater than months. Whenever we talk about acute pain, those analgesic requirements tend to decrease over time. But when the pain is chronic, the analgesic requirements will actually increase over time, especially when our patients are taking strong medications such as opioids. Something super important to remember is cancer pain. Cancer pain is pretty much nociceptive. It's pretty much visceral from pain tumors. Most of the time, it's going to be chronic, so it will be subject to all the characteristics of chronic pain that we previously mentioned. However, cancer pain can also be neuropathic. Um, the pain that patient experience whenever they're cancer patients might be subjective to either the type of cancer that they have or the treatment that they're taking. So something very important to consider whenever we're talking about cancer patients. And so in order for us to properly diagnose and treat pain, we have multiple pain assessment tools that providers tend to use, again, in order for them to come up with a more accurate diagnosis. The first one that I want to talk to you guys about is the OPQRST. O stands for onset, which pretty much asks when did the pain start. The P is for provocation or palliation, which stands for what makes it worse, and also what helps to alleviate that pain. The Q stands for quality, so we pretty much ask the patients to describe that pain. R stands for region and radiation, which is pretty much about location. Where does it hurt? The severity is how much pain the patient is experiencing. The T obviously stands for time, which is how long have you had it and has it gotten any better or worse over time. And then last, we have the U, which stands for usual activities. And this pretty much asks, how does the pain affect your usual activities? So these are very important things to know because, like I mentioned earlier, it'll help your doctor understand your pain. It'll help understand also the treatment that will further benefit the patient. Another pain assessment tool that we have, it's called Socrates. The S will stand for sight, the O for onset, the C for character, the R for radiation, A for associations, T for time course, E for exacerbating/relieving factors, and then S will be severity. And these are pretty much similar in terms of like the type of questions that they ask and the information that they are trying to obtain from the patient. We also have PEG, pain intensity and interference score for chronic pain. The name says it itself. This is a tool for patients that are experiencing chronic pain, and it pretty much has three components to it. We have the P, which is the pain intensity, and it pretty much asks what number from 0 to 10 best describes your pain in the past week. There's also the E, which stands for enjoyment of life, and it pretty much asks what number from 0 to 10 describes how and during the past week has this pain interfered with your enjoyment of life. Lastly, we have the G, which stands for general activity, and it pretty much just asks what number from 0 to 10 will describe how during the past week has your pain interfered with your general activity. something that I will like to mention, and I will talk about it later in the presentation, pain has a direct effect in the quality of life. So proper pain treatment can significantly improve our quality of life. So something very important to keep in mind. Like I said, how does pain impact the quality of life? So pain is pretty much considered to be one of the most important determinants of the quality of life, and it is strongly associated with poor quality of life. So once again, proper pain control can significantly improve our quality of life. So in terms of, again, how does our pain impact our health? We have physical factors such as lack of energy, fatigue, sexual activity, sleep problems. We can also have physiological and well-being negative effects, such as a decrease in our positive emotions, our cognitive activities, and also our self-esteem. The independence level can also be impacted. A more specific example will be our ability to move, our activities of daily living, and also it can increase our drug dependency in order to help fight that pain. There can also be environmental factors such as the physical security, availability of social services, and then job satisfaction. So as you guys can see, pain is a serious matter for health and for the quality of life. So how do we treat our pain? We need to start by using our validated pain assessment tools whenever it's possible. It is important to remember that pain by itself is not a vital sign, which means that we need to dig deeper into what is our patient experiencing. We need to obtain the most amount of information possible in order for us to get a proper understanding of what our patient is experiencing. And then we need to outweigh the risks versus the benefits of the treatments that we actually decide to use for that pain. So I truly like this image because I feel like it shows a proper approach to pain management. As you guys can see to your left, we have 4 different patients. We have patient A, patient B, patient C, and patient D. These 4 patients consulted their providers. They underwent a diagnostic evaluation and a biophysical approach. The provider properly analyzed all the possible alternatives to help these patients. When necessary, providers can also consult other interdisciplinary teams in order to come up with the best treatment. I do want to briefly mention all the possible alternatives that we have in order to achieve that pain management. When it comes to medications, there's NSAIDs and other over-the-counters. However, there's a bunch of things that are non-pharm related that can be considered for our patients, such as yoga, massages, behavioral health, and many, many other things. Now, once the provider analyzed the patient, he asked the right questions, and he investigated into what is the pain for each patient. An integrative treatment plan was designed for each one of them. And I do want to emphasize that whenever we treat pain, this has to be something very patient-centered and patient-specific, because not every single patient will benefit from medications or from non-pharm. So this has to be a very well thought plan in order to treat this patient. So for example, patient A benefited from NSAIDs, yoga, and nerve blocks in order to control that pain. when it comes to patient B actually required short-term opioids with behavioral health and physical therapy. Patient C was able to alleviate her pain by using acupuncture. However, she did require surgery and self-management. And then patient D required gabapentinoids, Tai Chi, and then the epidural steroid injections. So once more, this is something very patient specific. So effective pain management, again, is best achieved through a patient-centered focus, particularly for chronic pain. Multidisciplinary approach will help improve patient outcomes. Like I mentioned, pharmacotherapy may or may not be needed. And when it comes to the pharmacologic options, we have either opioids or non-opioids to treat pain. However, important to remember that the opioid epidemic has created a surge of interest in considering non-opioid pharmacotherapies for the treatment of chronic pain. So in terms of non-pharmacologic pain alternatives that we have to properly treat pain, we have cold treatments such as ice packs and gel packs. Cold treatments are preferred whenever that tissue is damaged, and some common examples include like sprains, strains, or freshly pulled muscles, as it will help reduce that pain and inflammation. We can also have hot treatments like microwavable, electrical, and chemical. I do want to mention that heat is preferred to soothe those sore muscles that can cause back or neck pain, as it will help open those blood vessels and then promote healing. Now, we want to use a heating pad or a warm towel to help relieve muscle aches and tensions. However, it is very important, if you're considering any hot treatments, to be careful with burns. We also have the transcutaneous electrical nerve stimulation, or TENS. However, this is contraindicated in patients with pacemakers. So in terms of the common classes of pharmacotherapy medications for pain, we have acetaminophen, NSAIDs, anticonvulsants, antidepressants, musculoskeletal agents, anxiolytics, and then opioids. And I will be talking about each one of them within the next slides. So acetaminophen, in terms of its mechanism of action, it's pretty much unknown, but it is believed that it inhibits some of the cyclooxygenase pathways. And by doing that, it pretty much alleviates that pain not associated to inflammation. Tylenol is effective for mild to moderate pain whenever it's taken over the counter. And like I pretty much mentioned, it lacks those anti-inflammatory effects, but it does has analgesic, and it will help reduce fevers. Tylenol is contraindicated with for patients that have a history of liver disease due to the dose-dependent liver toxicity. So super important, if you happen to suffer from liver disease or have any liver injuries or liver damage, you should avoid Tylenol. And again, super important, without a prescription, the maximum dose that you can take over the counter is 3,000 milligrams or 3 grams per day. We also have the non-steroidal anti-inflammatory drugs, or NSAIDs. These medications work by inhibiting the activity of both the COX-1 and COX-2 enzymes. And by doing this, they will inhibit prostaglandin production and thus reduce that pain and inflammation. They come in a variety of dosage forms. However, it is very important to consider patient-specific factors or comorbidities if you decide to go with an NSAID, and this include, history of bleeding, hypertension, cardiac disease, renal dysfunction. So if you suffer from any of these, you have to avoid the NSAIDs and go with Tylenol. Just listing some common agents, we have ibuprofen, naproxen, and diclofenac. The over-the-counter dosages will vary depending on the specific agents. And like I previously mentioned, high blood pressure, history of cardiac complication, and renal dysfunction are contraindications to using these medications. So Tylenol will be a better option for mild to moderate pain. We also have anticonvulsants. In terms of their mechanism of action, these medications will interact with the binding site in the brain membranes and reduce brain activity. And these specific ones don't have any direct activity on GABA receptors. So it's a different mechanism of action to help with the pain. Their first line for neuropathic pain or nerve pain, and it is recommended that they are added to other analgesics such as NSAIDs or opioids for cancer or chronic pain. In terms of their side effects, they will make you feel very sleepy, tired. They may cause like drowsiness and mood changes. And then they might be subjected to drug interactions with drugs like losartan, caffeine, naproxen, morphine, and cimetidine. So something very important to keep in mind as well if you decide to go with anticonvulsants for pain. We also have antidepressants such as our TCAs. The most common agents are amitriptyline, nortriptyline, or desipramine. Now, when it comes to dosing these medications, your doctor will pretty much start at the lowest dose and then titrate as needed, because these medications are subject to a lot of side effects, most importantly, the anticholinergic side effects. They can also cause sedation, weight gain, cardiovascular complications, and an altered mental status. So these drugs are not what you will see a lot for pain treatment, but they represent an alternative. There's also the SNRIs like duloxetine and venlafaxine. They're also subject to the same dosing regimen. Your doctor will start it at a low dose and then will titrate it as needed to achieve that pain control. When it comes to their side effects, they can also cause sleepiness, dizziness, insomnia, fatigue, nausea, constipation, and also night sweats. However, with SNRIs, they have specific dosages for pain treatment. Now, when it comes to duloxetine, 60 milligrams, it's considered a good dose to treat pain. And then between 150 to 225 milligrams per day for venlafaxine to treat pain. We also have the musculoskeletal agents such as baclofen, tizanidine, cyclobenzaprine, or carisoprodol. However, these agents are subject to a lot of sedation and they can further increase the risk for falls. So if you are taking these medications, be very cautious because of that sedation that they can cause. Carisoprodol is no longer recommended because of how addictive it can be. And then these drugs are pretty much not commonly used in our older population, again, because of that sedation and because of that increased risks for falls. We have anti-anxiety medications, and these are pretty much just prescribed to treat the anxiety associated with the pain. These medications do not treat pain itself. It's just the anxiety that is associated with the pain. As uncontrolled anxiety can further exacerbate pain. So this is why a provider might consider an alternative like this one, just to help control that anxiety. Some of the most common examples include the SSRIs, SNRIs, and benzodiazepines. However, the benzos are not recommended in our older populations, but some patients can actually see some benefit. And the reason why they're not recommended is, again, they're extremely sedative and they can also increase the risk for falls. So something very important to consider whenever patients take benzodiazepines. Now, opioids. Opioids pretty much work by blocking pain signal transmission to the brain. They're considered controlled to substances. So just as an FYI information, whenever a medication is considered a controlled substance, they will get a number. And then if the number is lower, like for example, we have that opioids are C2, this means that these medications have high risk of addiction. The benzos are C4s, so if you compare one to the other, opioids have a greater risk for addiction. Opioids are subject to a lot of legal regulations, and this is because of the opioid epidemic, which has been an extremely difficult public health concern. They're not first line for any type of pain treatment, and they're usually saved for last. They're more commonly used in cancer and chronic pain. Some of the side effects associated with opioids are respiratory depression, constipation, sedation, and then the potential for abuse, like I mentioned. So some general opioid recommendations: non-opioid therapy is pretty much considered the first line, and you should only use an opioid whenever it is clinically appropriate, and pretty much your doctor will prescribe the opioid whenever it is clinically appropriate. Now, if an opioid is being considered, clinicians need to use evidence-based guidelines in order to come up with the proper treatment for that pain. In terms of duration, type, and dose of opioid therapy, it should be patient specific, and it should be based on the patient's unique condition. Usually opioids will be prescribed the lowest dose for the shortest period of time. And then opioid therapy should only be initiated when the benefits actually outweighs the risks, and or the patient is experiencing that significant acute or chronic or cancer pain, again, because of like the side effects that opioid have. So in terms of the future of pain treatment, there's actually a research that has been conducted in the University of California in San Francisco, and they have actually discovered 6 new molecules that do have analgesic properties, and they act in the same receptors as clonidine and dexmedetomidine do. These molecules will not be as sedative as clonidine or dexmedetomidine. They will not cause any type of addiction, and they do have powerful analgesic properties. However, this is still something very new, and then a lot of clinical trials need to be conducted in order for researchers to determine the safety and efficacy of these drugs. But it is good to know that there is things being researched, and there might be alternatives in the future to help with pain control. These are my references, and what questions do you guys have for me?
You might be lucky, Angel. So Angel, your previous slide on the new options that are potentially in development,
Mhm.
That study,
Mhm.
the researchers there,
Mhm.
how far along is the research on
I think
on
they're
those
just doing
molecules?
testing in like animals and stuff like that. I don't think a study has been like formally developed or anything. So this is just like very premature right now. But they did discover those 6 molecules that they're very similar to like the clonidine and the dexmedetomidine. But this is it's very premature right now. But I
Okay.
do think that, if research continues to be done, I think a good clinical trial will be performed. And I do think there's a lot of validation to these alternatives once again, the proper clinical studies are conducted.
Okay. You might not have any more questions. I don't hear any, and I don't see anybody unmuting, so